Welcome to yet another WiSH webinar done by WiSH. For those of you that aren't familiar with WiSH, WiSH is the BITS Sports and Health, and the members of WiSH are medical professionals that are interested or have a special interest in treating sports people across Gauteng. This is done with a specific focus on academics and research into the field of sports medicine. Now, these webinars wouldn't be possible and they wouldn't be able to be presented free of charge if it were not for our sponsors. So I'd just like to thank our sponsors for this evening, which is Human Vita. Now, tonight's talk, which is based on exercise after pregnancy, is hosted by myself. My name is Belinda Waghorn, and I head up the WiSH running interest group for Gauteng. If there is anybody on the group that isn't already a member and would like to be, please pop me an email. I'll put my email address in the chat box a bit later for you to access. So this evening, again, the webinar is about exercise after pregnancy. Now, with specific reference to running, in the past, there was a guideline of about 6 to 8 weeks that were given to women for returning to running after pregnancy. But giving birth is quite a traumatic event on the body, and especially on the soft tissues. So therefore, recent studies have shown that these soft tissues are only just completing their healing process at this point and are far from the strength that they're required to be before returning to specifically running. Having said that though, I'm not the expert, and it's the one field of running that I don't have any experience in. Therefore, this evening, I have selected 2 excellent speakers that will be discussing this topic. Please, during the course of the talk, if anybody has any questions, please pop it in the Q&A box so that we can go through those questions, and depending on how many there are, we will try to answer all the questions before the end or the close of the webinar this evening. So the first of my speakers this evening is Dr. Etti Barsky. Dr. Barsky is a general practitioner and sports physician who has always had more of an interest in the recreational athlete. For over a decade, her passion has been exercising during the pre- and postnatal period. She has recently extended that interest to the broader public, aiming to inspire and motivate lifestyle changes to her patients and to teach them that exercise is medicine, which is one of the big premises of WiSH. Of importance for tonight is that Dr. Barsky was the training director and partner of Previ Belly South Africa from 2005 to 2018. Her field of interest being exercise during pregnancy and in the postnatal period. She became the lead author in the SASMA position statement on exercise in pregnancy and the postpartum period, which was published in 2012. Dr. Barsky is a mom of 3 young sportsmen who continually improve and challenge her working knowledge of cycling, swimming, and cricket. Unfortunately, Dr. Barsky, running is missing there, so we're going to have to work on that. And she herself is a recreational runner. Over to you, Dr. Barsky.
Thanks so much, Belinda. Thanks to Prof. Patricia and Belinda and the whole WiSH team for thinking of me and inviting me to come and share my knowledge with you and to present this evening. I'm going to quickly share my screen and we can go. Right. So before we start, just to let everybody know, all the babies that you see in this slideshow are mine, and they have not yet been harmed in the making of this presentation. Right, there we go. So that's said baby, one of them that has not yet been harmed. Right, so now without any further ado, let's enter the world that is women in exercise. Before we talk about returning to sport postnatally, we need to talk about some general principles and understand the relationship between women and exercise, and then the effects of pregnancy and labor on a woman's body as well. There's a greater risk of injury for women as compared to men when a woman exercises, simply because of the anatomical and physiological differences between a woman's body and a man's, and the most frequent issue being overuse injuries, specifically of the thighs and knees, and with the most frequent conditions being patellofemoral pain syndrome and anterior cruciate ligament injuries. Okay, so here we are, just the quick general principles. As I mentioned, just a quick overview of the difference, anatomical differences between a woman's body and a man's, and how a woman is predisposed more often than a man to thigh and knee injuries. Are we progressing along nicely over there?
Yes.
Great. Right, carrying on. I'm now going to open the can of worms that is pelvic floor dysfunction. And while pelvic floor dysfunction in female athletes is a talk on its own, I need to mention a few important points because, as you will see just now, pregnancy really sets these worms free. Over the past decade, there's been an exponential increase in the number of published studies concerning pelvic floor dysfunction in female athletes. Research indicates that female athletes participating in strenuous sports are at a higher risk for pelvic floor dysfunction, specifically urinary incontinence. The prevalence of pelvic floor dysfunction in female athletes is dependent on several factors, including the type of sport they do, the training intensity, training frequency, and the years of involvement in that particular sport. And the highest prevalence rates of urinary incontinence were found in sports that involve running, jumping, and high impact landing. I love this slide. It really encapsulates the pathophysiology of pelvic floor dysfunction in female athletes. And as you can see, there is a complex interaction between neuromuscular, biomechanic, morphologic, anatomic, and metabolic factors. Just you'll give you all a minute to take that all in. And now let's see what happens when you fall pregnant. Oh, screen's gone blank.
We can still see it.
Okay. Can you see that? I'm not sure what happened here.
That's now your slide that's headed pregnancy.
Right. So pregnancy. I'm looking at a blank screen on the one side, so I'm going to just try and ignore that. If you guys can see everything, then that's fine. I'm going to highlight the adaptation that have a bearing in the postnatal period, specifically with return to exercise postnatally. But essentially what you need to know is that the mother's body adapts on every level, physiologically, mechanically, metabolically, in order to support the pregnancy. So looking at the specific changes we want, that would be cardiovascular changes, where there's enhanced maternal blood volume and increased cardiac output. And in the respiratory system, we see adjustment of lung volumes, increases in the tidal volume and minute ventilation, and then decreases in the residual volume and expiratory reserve volume. And essentially what that means is it's actually improved lung recruitment and improved lung function. Moving on to the musculoskeletal changes that happen during pregnancy, we have increased circulating relaxin, causing increased lumbar lordosis, increased thoracic kyphosis, pelvic instability, abdominal diastasis, and on top of that, we also have increased body weight and a higher risk for carpal tunnel syndrome. Thoracic kyphosis is compounded by the increasing breast size and mass, and even more so postnatally if the athlete chooses to breastfeed as well, because obviously that needs to, the breasts get filled with milk. Also, bearing in mind a woman's predisposition to thigh and knee injuries, we need to know that pregnancy causes a forward and downward shift in the center of gravity due to the expanding uterus. And this means that the load of increasing body weight now gets carried in the knees as well, and can also result in quadriceps atrophy. So it's something to bear in mind if you already have a pre-existing knee injury. The most common complaint in pregnancy is lower back pain, of which the cause in most cases is pelvic instability. It can present with either sacroiliac joint pain or pubic symphysis pain, and this is really due to the circular nature of the pelvis. The sacroiliac joint, just to refresh everyone, is the largest load-bearing joint in the body. The bony components of the pelvis have a self-locking mechanism, which is integral to the SI joint stability, and this is known as form closure. Assisting form closure posteriorly, we have the sacroiliac and sacrotuberous ligaments, and as you can appreciate with the secretion of relaxin, this whole complex network is compromised in terms of stability, and this compromises form closure of the pelvis. Luckily though, we have myofascial slings. These are various muscle groups that when they work together, exert a compressive force on the SI joint and helps it maintain stability. And that's called force closure. We have 5 myofascial slings in the body, 2 anteriorly, 2 posteriorly, and 1 deep longitudinal sling. The anterior oblique slings involve the external obliques and the internal obliques connecting with the contralateral adductor muscles via the adductor abdominal fascia. The posterior sling system involves your lats, thoracolumbar fascia, and the contralateral glutes. And then the deep longitudinal sling connects the erector spinae, multifidus, the thoracolumbar fascia, the sacrotuberous ligament, and biceps femoris. And in pregnancy, it's recommended to design specifically directed exercises with these biomechanics in mind. In other words, it's important to activate and involve these muscle sling systems to help maintain pelvic stability through force closure because form closure is compromised. And the same principles need to be applied in the postnatal period, which you will see as we go along in the talk. Then we have abdominal diastasis, which just freaks everybody out. It is a frequent phenomenon in pregnancy with a prevalence of 30 to 70%, and there are no obvious risk factors. Working these muscles in pregnancy, and dare I say postnatally, is generally a fine balance of keeping the muscles activated so that the diastasis can be controlled, but not overworking them and thereby causing counterproductive results which can aggravate the condition. Right, moving on to the big reveal, which is to see what is going on now during labor and delivery and the impact of pregnancy itself on the pelvic floor. Now, just as no talk about exercise in pregnancy would be complete without discussing pelvic instability, no talk about postnatal training. In fact, we cannot even think about postnatal training without considering the pelvic floor. And the reason I've included these particular pictures in the slideshow is to help everyone appreciate that regardless of the mode of delivery, whether it's cesarean section, vaginal delivery, complicated or not, the pelvic organs, and by implication the pelvic floor as well, have had 9 months of increased weight and pressures bearing down on it. This statement is really important to internalize and just read through together carefully. Pregnancy that goes beyond 20 weeks, regardless of the mode of delivery, greatly increases the prevalence of major pelvic floor dysfunction. So here it is, the pelvic floor in all its funnel-shaped glory. It seals a cavity known as the levator hiatus, which is the largest portal for potential herniation in the body. It consists of 3 components: the levator ani muscles, which are the largest component, the coccygeus muscles, and the fascia covering of the muscles. Levator ani is made up of 3 muscles: puborectalis, pubococcygeus, and iliococcygeus. Some fibers of the puborectalis muscle, called the prerectal fibers, form another U-shaped sling that flanks the urethra in the male and the urethra and the vagina in the female, and is also referred to as pubovaginalis. Their job is to maintain urinary and fecal continence during abrupt increases of intra-abdominal pressure, such as sneezing and coughing. And iliococcygeus is the actual levator of the 3. It elevates the pelvic floor and the anorectal canal as well as the anus, and thereby sealing it, and is important in the context of defecation and fecal continence. Contraction of iliococcygeus also assists the stabilizing of the flexura perinealis, which belongs to the rectum. And this area begins to widen during pregnancy, long before the onset of labor and irrespective of the planned or unplanned mode of delivery. So what does this pelvic floor actually do? Well, it assists in maintaining both urinary and fecal continence, as I've mentioned. It supports the abdominal pelvic viscera. So remember I said that it's the levator hiatus is the largest space in the body. It's essentially the bottom of you. If you did not have pelvic floor muscles, your guts, your pelvic organs, everything would just fall out. It actively contracts during activities such as forced expiration, coughing, sneezing, vomiting, orgasm, and in terms of in exercise, running, landing, jumping. It forms part of the core stabilizing muscles and contributes to pelvic stability as well. Pregnancy itself places a lot of strain on the pelvic floor. We have the relaxant doing all this remodeling work, the weight of the baby, the increasing weight of the baby during the pregnancy, the increasing weight of mom, the increasing weight of the uterus, the placenta, the fluid, and repeated straining of the pelvic floor area due to constipation, which is a common occurrence in pregnancy. Moving on to labor and delivery, there is lots of potential trauma and damage that can happen to the pelvic floor during the actual delivery process. And the conditions that you see there, such as prolonged second stage, a high birth weight, and more specifically damage to the anal sphincters, the pudendal nerve, third and fourth degree tears, while most of it does apply to vaginal deliveries, and they can actually be controlled to an extent by the obstetric healthcare worker, it's important to remember that in a lot of articles where they've assessed women a couple of years down the line, the mode of delivery was irrelevant, and recovery of the area generally takes 4 to 6 months postpartum. Postpartum MRIs and ultrasounds have shown that the levator antemuscle defects can resolve in a time frame of anything from 6 weeks to a year. So this picture was taken at the start of my first postpartum period, and it's in honor of the newborn that you can see there, who turned 18 3 days ago. I can't believe it. So what is this postpartum period all about? It's classified into 3 time frames: delivery or birth until you're discharged from hospital, which is usually about 2 or 3 days, depending on the mode of delivery, then day 3 to 6 weeks later, and then 6 weeks to 12 months after delivery. And this is where the big shift in the thinking has changed. As Belinda mentioned in the intro to the talk, traditionally, the postpartum period was thought of as those first 6 to 8 weeks after you've had your baby, and then boom, back you go to normal life. And our research and our studies have shown that actually this time frame runs much, much longer. So what do we need to consider as we return to sport? Well, first is going to be mode of delivery. Was this a normal vaginal delivery, or was it a cesarean section? If it was a normal vaginal delivery, were there any tears? Was there an episiotomy? What was the size of the baby? And if everything was uncomplicated, you can pretty much resume training when you're ready. And if there were complications, you need to wait until everything is fully healed, which is roughly 6 weeks later. Just for the non-medical background people out there, the reason I have differentiated between a tear and an episiotomy is because a tear is an uncontrolled event. It happens with a difficult vaginal birth, where as the baby crowns, the pelvic floor gets torn, and you cannot control how badly the tear goes in terms of size and depth, compared to an episiotomy, which is carried out by the obstetric caregiver, and it's a controlled incision to assist with the delivery. If there was a cesarean section, then we need to consider, was it an emergency or was it an elective procedure? And it's usually best to wait until 6 weeks for the 6-week check before resuming training. Back to the vaginal deliveries, there are no studies determining the ideal timing of return to strenuous exercise. And the International Olympic Committee guidelines recommend that after a complicated vaginal delivery, it is best to minimize activities that generate large increases in intra-abdominal pressure and or repetitive high impact for several months postpartum. With a cesarean section, the decision on when to resume training actually depends on the reason for the cesarean, because we need to know were there any comorbid issues. Was there preeclampsia, anemia? How badly did the mom bleed? Was there delayed wound healing? Has the post-op pain resolved? And it's important to bear in mind and advise our athletes that a cesarean section is abdominal surgery at the end of the day, and we need to be mindful of the time that it takes for the abdominal fascia to heal properly. The abdominal fascia regains only 50 to 60% of its tensile strength at the 6-week post-op mark. And round about the 6 months down the line, it can regain anything between 70 to 93% of its tensile strength as compared to prenatal. There are no specific guidelines for returning to competitive sport that deviate from what I've already mentioned, and it is very much an individualized process. You'll hear me stress this all the way through the next couple of slides. There are also no specific investigations that need to be done in order to resume training, but there are 4 main conditions that we need to watch out for, and they are almost like contraindications, and they are heavy bleeding, localized pain, infection, and illness. And while this is really mainly applicable to the first 6 weeks, so it's something you would watch out more for in women who've delivered vaginally as opposed to the cesarean section, because you wouldn't be seeing them in that time frame, it's something to bear in mind for the whole postnatal period. Moving on to then, we need to consider our postpartum physiological adaptations. A quick refresher on what happened in pregnancy. We had increased cardiac output and increased stroke volume. In the respiratory system, we had improved lung recruitment. So the postpartum physiological adaptations can affect an athlete's performance either to advantage or disadvantage, because you'll see that with cardiovascular adaptations, they persist postpartum, and they can even be enhanced by subsequent pregnancies. In the few studies that examine the parameters of cardiac output and stroke volume, they seem to note that there never seems to be a return to preconception values, even though the values return to the normal range. The respiratory adaptations return to baseline within 6 to 12 weeks. And then the musculoskeletal changes can take up to a year to resolve and hardly ever really return to the prenatal condition. And this relates specifically to pelvic stability. Then we need to think about breastfeeding. You can see the 3 main concerns that are highlighted, and let's talk about them one at a time. So there's no evidence to support any changes to the quality or the composition of breast milk during exercise. One of the main concerns is that during maternal exercise, there will be a lactic acid fluid buildup in breast milk, which would then affect the feed or the taste of the milk. But this has not been substantiated by any study. The only thing that has been shown is that the salty taste of mom's sweat on the breast can affect baby's latching. And this is a problem that we can easily overcome by expressing breast milk and then wiping the nipple and the areola with the breast milk if the athletic mom hasn't had a chance to shower between her training session, her event, and a feed. With regards to energy expenditure, there is increased caloric expenditure with breastfeeding, which can impact an athlete's postpartum weight loss and possibly her performance, especially if her nutrition and her hydration are not adequate. So nutrition and hydration are really paramount for, or should I say adequate nutrition and hydration are paramount for achieving successful results for a breastfeeding athlete as well. Practically, you want to know how to time, it's ideal to time a feed with an event. It's not always possible. So if you can time a feed with a workout, a training session, or an event, it's best for the feed to happen before so that the breasts are as minimally engorged and as light as possible. And if this isn't possible, then you can always express a feed. This puts on less pressure on the mother to be there for the feed physically, and then she's able to attend to herself and focus on what she wants to achieve at that particular time. I cannot stress enough the importance of adequate breast support in a breastfeeding athlete. There are many athletes out there that couldn't push themselves to a new intensity for the simple discomfort and the feeling of heavy breasts. So it's really worthwhile investing in a good quality fitted bra that offers both support but not intense compression. Well, I think the pictures here say it all. We all know the important relationship between sleep and athletic performance, and the early days of parenting are notoriously associated with sleep deprivation, and a poor night's sleep needs to be factored into a training session. Having said that, though, the positive effect of exercise on sleep quality is also known. So we need to individualize a program, again, for a particular athlete. Some days she'll be able to give it her all, and on others, she will just need you as her support to just celebrate that she put aside time to do something for herself and come and train. Please be alert and mindful if your athlete complains of excessive fatigue. It may be a red flag for postnatal depression. The transition into motherhood can be complex and stressful. International statistics show that 10 to 15% of women will suffer from postpartum depression in the first year after giving birth. These stats are representative of the South African population as well. It's not uncommon for depression to set in during pregnancy, and we refer to this as perinatal depression. Postpartum depression has been described as the thief that steals motherhood and is one of the most common complications of pregnancy. I'm not going to go into it in too much detail. I just want you to appreciate the 3 different types of postnatal depression. The baby blues pretty much is par for the course. Most women have it in that first week. For those of you in the audience who have had a baby, you know that teary emotional feeling you feel usually on day 3, usually on the day that you get discharged from hospital if you've had a Caesar, or just as you get home. If you were discharged the day before, it's all normal and it does resolve on its own. Postpartum depression is a more clinical diagnosis, usually happening evolving in the 3 months postpartum. You have symptoms that persist daily for more than 2 weeks, and the mother needs to seek professional help, or her family needs to help her get that professional help, and more times than not, medication is needed. Postpartum psychosis you don't necessarily see in your athlete, and unless she perhaps started training a bit soon. It's usually in the first 4 weeks after having had a baby. It's a medical emergency. It requires hospitalization. So it's crucial to remember the benefits of exercise on mood. Again, we need to balance motivating our athlete to train so that she can reap the psychological rewards of exercise, but also we need to minimize any pressure placed on her with regards to performance. And sometimes this can be an expectation or a pressure that she puts on herself but doesn't verbalize it. So it's really important to watch out for. And now for the drum roll, our biggest consideration when it comes to returning to sport postnatally is pelvic floor dysfunction. It's characterized by urinary incontinence, fecal or flatus incontinence, pelvic organ prolapse, and sexual dysfunction. And sometimes it can really present quite sneakily as a lower back pain that just isn't going away, and you can't quite figure out why. Remember, the pelvic floor is necessary for pelvic stability too. So if you just start asking your athlete about symptoms of pelvic floor dysfunction, more times than not, you will find that she answers yes to one of the 4 conditions you can see in front of you. It is so important to communicate about these issues with your athlete. None of this is normal, though it may be a rite of passage, excuse the pun, and this needs to be addressed and managed appropriately. The main thing we need to do is we need to modify an exercise plan to accommodate a weak pelvic floor. Some suggestions, which I know Dr. Corlia is going to delve into in much more detail than me, but we want to change the impact of a workout. We want to focus on hip abduction, less repetition, but really most importantly, we need to educate our athletes on being mindful of their pelvic floor. You need to teach your athlete correct breathing, muscle activation, and how to support your pelvic floor, as this is paramount for a successful rehabilitation and eventually an eventual return to pre-pregnant exercise intensity. So practically what else can we do? Teach your athlete about signs of pelvic floor fatigue. Don't be shy to talk about them, even if you're a male. So here, the signs are in front of you. Just if you're unable to feel activation, by that I mean if you feel that you cannot grab hold of your pelvic floor, that is a sign. If you start to leak urine, if you notice a heaviness or bulging, and teach your athletes when is enough, how much is too much. And if you're feeling symptomatic during exercise, if you feel that you cannot hold onto your urine during exercise, or if you're feeling a pressure even after exercise, it was too much, and your session needs, your plan needs to be adjusted accordingly. It's very challenging to train the pelvic floor. The fatigue rate is high. It's a hidden muscle, so it's very difficult to show someone how to do it, which is why we have women's health physios. That's why they're so important. There is such poor patient awareness, lots of stigma, and you can't assume that transversus and the pelvic floor working together. You really have to teach someone how to do that. There are a multitude of benefits to exercising postnatally, not least of which is a valid reason to give a new mother and the athlete time for herself, which is such a precious commodity of motherhood. Initially, it's just about making the time for yourself, get out the house and to get yourself to the tennis court, get your shoes on and get on the road. But then eventually you can progress to timing the workout with the feed. You eventually can not worry about the feed. And finally, you can then focus on performance goals and reach new heights of self-fulfillment and achievement. Thank you for listening.
Thanks very much for a really great talk. I learned a lot. It was informative, to the point, and really easy to understand. So thank you very much for that.
You're welcome.
Our next speaker this evening is Dr. Conia Brandt. So Dr. Conia Brandt has a PhD in physiotherapy. She was born and raised in Bloemfontein, but we won't hold that against her. She is currently the South African International Urogynecology Association Physiotherapy Representative. Oh, that is a mouthful. She's the SA representative on the International Organization of Physical Therapy for Pelvic and Women's Health, chairperson of Pelvic and Women's Health for the SASP, and treasurer of Sasha and Gauteng, and the EXCO board member on the National Committee. Currently, after crossing over from Bloemfontein in 2018, once she eventually got a passport to come to Joburg, she's a senior lecturer at WITS to continue her passion for integrating research, clinical practice, and teaching and developing women's health clinics suitable to the South African context, and she's part of the WiSH research group. Dr. Brandt herself has no children, like myself, and uses all her free time to do trail and road running, mountain biking, and swimming. In her own words, after she fell herself to pieces in 2019, she has given up road cycling. And then when she has some time off, she also plays the piano. Over to you, Dr. Brandt.
Thank you, Belinda. Just before I share my screen, I would just quickly like to ask two questions to the audience, and I hope they will just quickly type it in the chat. Otherwise, I won't be able to see it once I start screening. So my first question is, without referring back to Dr. Barsky's answer, what in your mind, before you came to this webinar, what time period is the postpartum time period? So from when till when? So I'm going to give you 30 seconds maybe quickly to type. I just want a couple of answers. So before you watched the first lecture, what was your idea of postpartum period time-wise? Just one or two answers in the chat. Okay, so you can see there's quite a couple of answers. 6 weeks, 6 months, 3 months, 12 months. Okay, right. So my next question is, what if you read an article in a magazine or in a journal? What is your understanding of, and something the title tells you, exercise or physical activity? So what do you understand under that? If there's in the title the effect of exercise on return to play in postpartum stage, what is your understanding of exercise then? So also just a couple of answers and then we'll continue. Okay, so there's running. Anything else that you think? Walking, physical activity, Pilates, 30 minutes a day, yoga, exercises, movement, recreational running, pelvic floor stability. Okay, so we'll come back to these answers. Thank you for those who posted in the chat. So you can keep on posting if you want. So I'm just going to share my screen now. Let me just get to the right one. Okay, so I hope you all can see that. I'm going to start presentation. Okay. So what are the issues that we need to look at in the postpartum period? So I'm going to quickly run through a couple of things. I told Belinda I'm afraid I might not have enough time to go everything in detail, but I would be more than willing to share some of the information afterwards that they can maybe mail to you as well. I'm quickly going to have a look at antenatal exercise, because that's quite important to determine your postnatal return to play stage and to do that effectively. So we're not going to spend too much time on that, but we're just quickly going to have a look at it, because it's not something you can ignore. It fits into the postnatal return to play plan. Again, luckily, Dr. Barsky has covered a couple of anatomical and physiological aspects again. I'm just quickly going to run through a couple of things. I'm going to look at it maybe from a more mechanical side, probably, and an exercise side, rather than an anatomical and physiological side. So you have the background now. So important, there's a couple of things that we need to understand when we talk about exercise postnatally, or antenatally for that matter as well. We have a couple of muscles working together, which is the core. It's actually just the inner part of the core, which is demonstrated here. It's the diaphragm, the transverse abdominis muscle is your deep abdominal muscles. It's the pelvic floor at the bottom, and then it's your multifidus muscles at the back. So you can see here, it forms a closed room, which actually controls the intra-abdominal pressure. Here on the right-hand side, we have the position of all the pelvic organs, the normal position of it. And then if we go on to the next slide, you can see what happens during breathing. And this is quite important. We have a movement of the pelvic floor muscles up and down, together with the diaphragm and together with the abdominal muscles as well. And all of these things can be affected when you fall pregnant, because a lot of changes take place. You have an increased lordosis, the abdominal muscles become stretched, the intra-abdominal pressure changes because there's an increased uterus with the baby inside. So all of your mechanics change actually, and this is what is important to remember when we treat these patients and when we give them exercises. This slide just demonstrates the interaction between all the different systems that we have. When we talk about motor control and exercise, there's always a couple of systems that we take into account. We always look at the joints, we look at the muscles, we look at the neurological factors, in other words, the nerves innervating the muscles, and then we look at the connective tissue that holds everything together. There's actually a more updated version of this, where on the inside of the triangle you have actually your systemic factors, the thyroid, the cardiovascular system, respiratory system, like Dr. Barsky indicated as well. Because without that, none of these will in any way function properly. So we have a couple of important systems that work together and that fits into this motor control model of us. So we have the urethrons and the pelvic support system. We have a look at the lumbar pelvic area. We have the pelvic organs that we need to look at. And then there's also the intrinsic muscles that we need to look at. And they all work together and can influence each other. So when one of these systems or one of these components are not functioning properly, we will sit with the problem in the end. Very important at the bottom is also not to forget about the behavioral factors and the external factors, the environmental factors, because that can also affect any of these systems if we don't look at that. And that is things like the psychological aspects. What is the support of the patient? And there's the personal factors, the patient's work. So a lot of these things that we sometimes forget to ask and take into account, we need to remember to work it into our manage and assessment plan. So what happens when you are pregnant? Mechanically, from a mechanical point of view, literally, if you can see here at the bottom, you get a bit of a squashing of all the pelvic organs, unfortunately. So no wonder sometimes the bladder will leak a bit. This is not the only factor, obviously, a lot of other factors as well. But mechanical wise, this is what can happen. So your whole intra-abdominal pressure system changes, your lumbar lordosis changes, your muscle function changes. your center of gravity displays, your pelvic position displays, and that again will have an effect on the whole lower limb and the kinetic chain, because it functions as a kinetic chain, closed kinetic chain, from the foot upwards to the pelvic area and into the lumbar area. So very important when we look at patients, not only pregnant patients and your postnatal, but we always need to look at least from lower thoracic lumbar area downwards when we assess these patients. So there's definitely a change in how we approach these patients, looking at from a pelvic and women's health physio point of view. It's not only focusing on the pelvic floor muscles, because there's such a relationship between all the different components. And if one of these components are affected, lumbar-wise, in the lumbar area, in the pelvic area, SIJ area, it can have an effect on any of the other components as well. So quickly, I'm just going to highlight a couple of things regarding antenatal exercise guidelines. And this is a very recent one, the Canadian guidelines. It's in the BJSM, but it was published. So if you want to read more specifically on it, you must please go and get this article. It's really a good one and an updated one. So just a couple of things that we need to highlight. So what is the recommendations? This is now antenatal. So all women without contraindication can be physically actively throughout pregnancy. Pregnant women should accumulate at least 150 minutes of moderate exercise intensity each week to achieve meaningful health benefits. And also remember, it helps to reduce pregnancy complications. So don't see it always as a thing that might cause problems or you need to be careful about. As Dr. Barsky said as well, we must rather look at the benefits of exercise and why people should exercise. It should be accumulated over a minimum of 3 days per week, but being active every day is encouraged. So we will come back to that active term. They should also incorporate a variety of exercise, aerobic and strengthening exercises for the best benefits. And then you must also try and start pelvic muscle training, because it is so much at risk during pregnancy. And as Dr. Barsky said as well, it's not really about the type of birth, normal labor versus cesarean section, because that's always a question. It's actually more about the pregnancy period and all those changes, as we saw just now, that's taking place and puts the strain on the pelvic floor. Pregnant women who experience lightheadedness, nausea, or feeling unwell, especially when they're lying flat on their back, should then just modify their positions not to do the exercise in a supine position. There are a couple of contraindications where we will not, rather not let the women do specific exercise. You can go through the list here, but it's, so if they have any of this, they should definitely get to a medical practitioner, gynecologist preferably. If there's any ruptured membranes, obviously, or premature labor. If there's any bleeding, it's always a contraindication, anti or postnatal. If they have a placenta previa after 28 weeks, preeclampsia, which is high blood pressure during pregnancy. If there's any intrauterine growth restrictions, if they have multiple pregnancies, especially if there's twins or triplets, you should take extra care. If there's uncontrolled diabetes, hypertension, and thyroid, and with the emphasis on uncontrolled. Remember, exercise will still help these patients, but make sure it's controlled. And any other serious diseases or disorders that patients might have. Then you have some relative contraindications. In other words, they can exercise, but you will just be careful. If there's, for example, recurrent pregnancy loss, there's a history of spontaneous preterm babies that they had. If there's hypertension, anemia, malnutrition, eating disorders, twins, pregnancy after the 28th week, and mild or moderate cardiovascular and respiratory diseases, and any other significant medical conditions. I think it's not any different from any other patient that we would treat. We will always ask these questions, and if there's any red flags, we will take a bit of care assessing them and monitoring them during exercise. This is just a table indicating some suggestions for heart rates that you can aim for during pregnancy, if they are younger than 29 or older than 30. And then obviously, you know, you have your higher risk patients if they come closer to 40 years of age as well. Then there's also a couple of safety precautions that you can take into account when you let these patients exercise. For example, avoid any excessive heat, especially if there's high humidity. Avoid activities where there's any physical contact or the danger of falling, because we don't want to put anyone at risk regarding that. Avoid scuba diving because the change in the pressure that you get, and the same with when you change altitude, high and low altitude. Be careful with that. And those considering competition or exercising significantly, that is different from the suggested guidelines, must rather consult a medical practitioner, because it does put much more load on the body and the systems. Maintain adequate nutrition and hydration. Always drink water before and after and during the activity, and know the reasons when you should stop your activity and consult with a medical practitioner. So those are the red flags that you also have indicated. So what are the reasons to stop? It's if you are short of breath and it does not resolve, specifically when you stop doing your exercise. You have severe chest pain, if you get uterine contractions, if there's any bleeding, loss of fluid from the vagina indicating a rupture of the membranes, or if there's any persistent dizziness or faintness that does not also resolve when you start when you get rest. So that's just a very quick overview of some of the important things of antenatal exercise. But for more detail, I would definitely refer you back to those guidelines, which are actually very comprehensive and compiled, and it's based on all based on evidence. So I asked you the question in the beginning: how long is the postpartum period? So you saw a lot of questions, answers pop up, and which are quite different from each other. It ranged from 3 weeks to almost 2 years. And my other question was, what do you understand under the exercise and activity? And you also saw the couple of answers that we had. If we had to look at more, there were probably more of it that overlap, but there's different answers. And this is quite a problem, or rather the problem that we have, because the evidence that we have that's related to musculoskeletal health and a safe return to exercise is very limited. And these are some of the reasons. We don't have any standardized terminology. So what exactly is the postpartum period? Everybody has a different definition of it. What exactly do we mean by physical activity or exercise when we write about it? Because it can differ from running to walking to the shop and back, or just picking up something or carrying something. There's also quite a dearth of literature when we are looking for return to sport, to high intensity exercise and specifically competitive sport. There's also claims that in some instances that musculoskeletal dysfunction after or postnatal is normal. So you have problems, you're not as you used to be, so just live with it. And unfortunately, that's also still the same in many instances, or the belief with pelvic floor dysfunction as well. And we also have quite a lack of interprofessional care models when it comes to postnatal care and return to sport. It's not the same as we have in other instances. For example, if you have a normal athlete or a normal athlete who is not postpartum in that sense, with an injury, you usually have your interprofessional team who takes care of the patient, but not the same accounts always for just a postnatal patient who doesn't necessarily have any injury, but you know, in essence, the antenatal or the postnatal situation is actually a type of injury, because the musculoskeletal function is not normal, as Dr. Barsky indicated, especially in those first 3 months. So despite all of this, we have this lack of literature and guidelines, and still postpartum exercise have been proven to have a lot of benefits. So we should really focus on getting the right guidelines to make use of all these benefits and get the patients back to exercise, because it improves psychological well-being, bone health, lower cholesterol levels, management of weight, and optimal blood glucose levels, amongst many others that's also of benefit to the patients. So when we look at return to play specifically, as we saw in the beginning as well in the first lecture, we have some physiological changes that at least persist 4 to 6 weeks after delivery. And then there was in the NCA guidelines, if an athlete's competitive season completed before her, I'm just going to move this that you can see, it's the 14th week of pregnancy, or season begins 6 to 8 weeks after her delivery, she might be able to meet her training and her competitive performance goals for the entire season. So we also must distinguish between a competitive player and just someone who wants to return to, for example, recreational running, because their programs will differ quite a bit. And as Dr. Barsky also said, you know, that despite guidelines, it must always be individualized based on proper assessment findings. With no patient, you can just follow guidelines without assessing. The guidelines is actually exactly what it's saying. It's just a guideline where you can try and fit your patient in, but your main decision must still be based on your assessment findings. So why must it be individualized? Because the physiological principle for strengthening is based on overload, specificity, maintenance, and reversibility, environmental factors and personal factors, and all of those things will be different in each patient. So for one patient, you can give us 10 exercises, 10 sets or 3 sets, and it might make her completely exhausted. And for the other patient, you can also give it, and it will have absolutely no effect because her muscles are much stronger than that. So therefore, you can't have a general program and just give it to all the patients. Some might benefit and some might not benefit at all. So this is a study that was done in 2020, or actually not a study, it's more a recommendation, a clinical opinion paper, that they suggest some phases for returning to sport postnatally. So in the first 3 months, they call it the recovery period, where you focus on all the physiological recovery things, the gynecological recovery, and wound healing, and if there's anything else that might be present, such as lumbar pelvic pain, if there's incontinence, pelvic floor dysfunction, if there's the diastasis of the rectus abdominis, this is the time we will focus on trying to make that all of that better. And then you go over to your rehabilitation phases at 3 months. And that can go over into phase 3, which is your competition or your return to play phase. And these 2 phases are actually quite continuous. You can go back and forth between these two phases, depending on what the individual findings are, depending on if there's any other injuries present, and your level of fitness after or postnatally as well. So in this period, you will focus on your strength training, your aerobics, your sport-specific exercises, biomechanical assessment, pelvic health assessment or treatment if it's indicated, and we will come back to this just now, and monitor and adjust any training and your competition goals. And then competition obviously is your return to your competence your competent level of performance. So if you're not ready or something's lacking, you will go back to this stage. So this is a very nice guideline, I think, in general to use or to show someone. Also, just to emphasize the importance of the normal recovery of all the physiological changes in those first 3 months. But we are actually dealing with 2 things here, because we have the postnatal considerations to take into account, and then we actually also have the sporting things that we need to take into account. when we look at return to play and rehabilitation, because Dr. Barsky also mentioned it, we have to look at the frequency that women are training, because in general, if you look at sport, the more they train, the more the intra-abdominal pressure is increased, and the more they, will tend to have problems with pelvic floor muscles if they are not aware of that specifically. Also, with strenuous physical activity that increase your intra-abdominal pressure, it can overload, it can damage your pelvic floor, the ligaments, the fascias, and it can also affect the contraction force of your pelvic floor muscles negatively. And athletes are at higher risk to develop urinary incontinence, loss of gas. It's just a different phase of fecal incontinence, sexual dysfunction, whether they are doing specifically high impact or strong effort activities. And it's just because all of this extra, specifically intra-abdominal forces that's created, put a lot of strain on these, on these pelvic organs in general. So even more so when you are postnatal and you're also physiologically quite vulnerable to increased strain and damage to the connective tissue. Then there's a couple of things that are also going to challenge you when a patient returns to play postpartum. Because there is a bit of general deconditioning because you were pregnant, you had some heavy weight to carry around, and you definitely did not run as much as you used to. Also, the type of delivery that Dr. Barsky indicated, whether you had normal or cesarean section, will determine your time of return. Postpartum depression may be a little bit of a setback. Gestational diabetes, incontinence, low back pain, and pelvic floor dysfunction, and some other factors which we will quickly have a look at. So general deconditioning, this is just an indication for us that we need to assess a patient properly. All muscle groups, bigger muscle groups, we need to assess the pelvic floor muscles, we need to assess the core musculature, we need to assess the breathing patterns. And because breathing is actually also, despite the coordination that we want between the diaphragm, the pelvic floor, the transverses and the multifidus muscles, it's also quite important for when they start doing exercise and the breathing pattern changes a bit. There was a study by Cardell that indicated a return to play program, which they found did not have any harmful effects. And they gave their patients a training schedule for 6 days per week, 2 sessions per week, which involved strength training for 72 minutes, and 2 sessions in each week, which involved 20 to 30 minutes of aerobic training with a specific heart rate of anaerobic training, and then also endurance training for 90 to 150 minutes at a heart rate of 120 to 140. I think some of these guidelines regarding training might have changed a bit also by now regarding endurance and strength. And then we see the nature of the delivery. So depending on whether it's normal delivery or cesarean section, your time for return to play will be different a little bit. Just always remember, when a patient can't return to play doesn't mean they don't have to do anything. That's why the assessment is so important. You can do things that will not put strain on the patient, whatever problem or complication they might have. So assess what is the problem and what you can do without putting strain on the specific area that needs to be protected still. Postpartum depression, they can have symptoms prior to and during pregnancy, and that may predict a bit of postpartum depression. But it is very important to remember that we actually use exercise to relieve mild to moderate symptoms of depression. So don't let that be something that might be, stop the patient from exercising. Rather let them do something that they enjoy doing, or that they will be doing, and that will help with the depression. And I think this is also very important when it comes to setting a mutual agenda with your patient. You need to prescribe them exercises that you know that they are going to do. You can't give them an exercise program, specifically if it's not maybe a competitive Athletes, high-level athlete, maybe they don't really like exercise, but we want them to exercise. So make sure you know what their likes, dislikes, and circumstances are when you prescribe exercise or activity to your patients. If patients have some gestational diabetes, mellitus, during pregnancy, they might be at a higher risk to develop type 2 later on in life. But again, exercise is effective means to treat this specifically, and of course, any form of diabetes. So the benefit of exercise here is definitely important. There might just be a couple of additional considerations that you need to take into account, obviously, monitoring the patients and giving them some advice on food intake and whatever type of diabetes they might have. And then again, pelvic floor dysfunction, which is actually, you know, what is important to consider as well, especially in that first couple of months before the patient returns to sport. We don't like them to return to sport before we have sorted these things out. So it could include any type of dysfunction postnatal. Could be urinary or fecal incontinence. Sexual dysfunction is usually associated with a hypertonic pelvic floor or pelvic pain. There could be overactive bladder, there could be flatus, any type of dysfunction. I'm not even putting in here sacroiliac joint pain or just normal lumbar pain as well. About 2/3 of premenopausal women suffer from some kind of pelvic floor dysfunction within the first year postpartum. And it's because there's a couple of changes that just take place when you're pregnant, and Dr. Barsky has also indicated some of them. There's pain, there might be some muscle and nerve damage. There might be a growth of the uterus that causes increased pressure and strain. The uretrovesical angle might change a bit, support of the bladder and neck and urethra consequently. There might be some physiological or hormonal factors that can affect the kidneys specifically. And that's going to all contribute to, you know, to urinary problems, incontinence, urgency, sensation of incomplete voiding. So if you find symptoms like this in the patient, you can't just assume, you know, it's a powerful muscles as well. You need always to rule out any other pathology that there could be in all instances, just like, you know, with the same that you would do with any other patient as well. So the dysfunction is usually due to the pathophysiological changes that we get in postpartum patients because of delivery and pregnancy, as we looked at all the mechanical changes that takes place and put muscles under strain and make them a bit weaker. So we just need to assess this patient properly and identify what the causative factors are and manage that accordingly. It should resolve within 3 months to a year after delivery if it's just, you know, associated with the changes that occur during delivery. Again, you know, when we assess these patients, it is important also to take into account, also we don't have any time, unfortunately, now to go into detail to that, on a proper pelvic floor assessment. So if you really suspect problems, make sure you send the patient to someone who is a pelvic floor physiotherapist that can do the necessary assessment and the testing for these patients if you are worried that there might be a specific pelvic floor dysfunction present. Sid Morkved in 2003 already have made some recommendations, and I think, or unfortunately, I think it's still applicable, you know, a couple of years later, that pregnant and postpartum women should be encouraged to perform pelvic floor muscle training to prevent and treat urinary incontinence. There's very good evidence on the treatment for urinary incontinence, especially postpartum, the effect of exercises on that. And then health services for women during pregnancy and after delivery should be increased. I think it's still the thing that we should be doing. Strategies to prevent and treat incontinence need to be implemented. Still something that we are actually struggling to do. You know, in the private sector, we have problems with medical aids, and in the public sector, again, we have resource problems. So we still need to look at that. And then pelvic floor muscle training should be incorporated sports and exercise groups in general to reach the women of all levels of physical fitness. And if we actually think about that, it's actually your high performance athlete that will almost be at a higher risk of developing some of these pelvic floor dysfunctions because of the increased load that they have due to frequency of training, the intensity of the training, and usually just the load of the training in general, which puts additional pressure and strain on the pelvic floor muscles and the surrounding areas as well. Again, remember, it's not, we always talk about the pelvic floor, but it's important to assess everything from the diaphragm downwards. We must also be on the lookout for low back pain or lumbar pelvic pain due to the mechanical changes that might occur. Increased lordosis, they have an increased weight, they have a different position of the pelvis, the center of gravity changes, and the muscles such as the transverse abdominal muscles and the other abdominal muscles is quite stretched and weak. Glutes are also quite stretched and weak. Hammies are quite stretched because you get an anterior tilt. So you have a lot of muscle imbalances that need to be corrected. And there's also the hormonal changes that leads to, more easily strain or more movement in the joints and on the more strain on the ligaments. And always be aware that patients that have a history of low back pain or previous pregnancies or an increased maternal age might be at a higher risk of having lumbar pelvic pain as well. Then there's just a couple of other factors I'm quickly going to scan through. The weight, because weight, causes increased intra-abdominal pressure and it causes increased load on the pelvic floor. So we need to try and manage that. It's always helpful to get a dietitian if it's really a problem and also get them to help the patient. I've talked about the breathing pattern and the importance of the coordination between the diaphragm and the pelvic floor muscles. And then also the diastasis rectus. Dr. Barsky also referred to that, but there is actually a positive evidence for the impact of running on a diastasis. So the important thing that we should actually look at is, does the patient have proper control of the abdominal wall with or without a bit of a diastasis? And that is the important thing that we need to assess. And make sure that they don't compensate when they start doing exercise. Again, just how, what is the diastasis? We have this line of fascia here between the rectus. And when you're pregnant, everything becomes stretched, unfortunately. And then sometimes it does not return to its original width like that. And it might look something like that. And when you cough and sneeze, it might be a bit more prominent and bulge out as well. Other factors that we also need to consider is the scar mobilization, if it's needed, where it's after an episiotomy, whether it's from a cesarean section. Breastfeeding, Dr. Barsky talked about that a bit, so I'm not going to waste more time on that. I just still want to get some guidelines, and then supportive clothing, which also falls under that a little bit, but also consider footwear if the patient needs a lumbar pelvic support or a kind of a brace. And then the right sportswear and sleep as well. It's very important for recovery psychologically and physically, and especially in the postnatal period where the mothers, they have the babies, they don't sleep as well as they should, and that can all have an effect on the training as well. And then also the red S. I hope all of you had previously attended the webinar, the WiSH webinar on this. Just remember, it's a very important thing to take into account postnatally as well, because the patients sometimes forget that they breastfeed and there's social pressure, and they don't take that into account especially when they exercise as well, that they need to adjust their nutrition accordingly as well. And sometimes they get poor sleep and they do excessive exercise because they put some unrealistic expectations from themselves or by other people, and this might all affect this whole energy deficiency circle that we don't want the patients to get into as well. So very important, return to running is not advisable when patients subjectively complain of urinary or fecal incontinence prior to or during commencement of running. If they have any symptoms of pelvic organ prolapse, that feeling of pressure, bulging, dragging in the vagina, if there's onset or ongoing bleeding that's not related to menstruation, and if there's any musculoskeletal pain, whether it's lumbar pelvic pain prior or to or during the commencement of running. And I think, you know, in a sense, is it's like we would treat any other pain with any other patient with an injury. We will not send them back to exercise if they still have pain, obviously, when they are exercising. So objectively, we would also not like to send them back if the pelvic floor muscles have a grade 3 or less strength, because that means there's not sufficient support for the organs in the pelvis. And we also, when there's reduced pelvic floor muscle endurance. Now, this is a relative thing, and personally, I still have a bit of a problem with all of these things that they still publish, because 10 fast reps, 8 to 12 reps of 6 to 8 second contractions at 60 seconds sub maximum 30 to 50% contraction. Now, you know, this is not, if you look at this endurance, it's far from enough for patients who are doing sport and who who might be running a marathon. You know, 10 fast reps, 60 seconds is absolutely less than 0% of what they need to do a 6 to 8 hour marathon. And that is the time when your pelvic floor muscles should give the necessary support. So this is published, but I don't always agree with it. And then also those are pelvic and women's health physios and gynecologists will know this, the POPQ system. You also, this is what we use to classify a pelvic organ prolapse. So when your genital hiatus and your PV distance is more than 7 centimeters when the patient Valsalva, we would not want to send it back, because it just means there's not enough support for the pelvic organs. Or if there's any physical evidence of incontinence during examination, that's usually when we ask them to sneeze, that we want them not to, it's that increased pressure that then leads to the incontinence. So this is just a summary of the key points of what we actually went through now. I'm not going to go through this. I just quickly want to get to the guidelines specifically that you can go back to and have a look at. There's also a nice load testing that we can do to see if the patient actually can sustain the load without having any symptoms. So you can do a video analysis, or you can just let them do these tests, and they must not have any feeling of heaviness, dragging, or incontinence, such as walking, single leg balance, squat, jog, forward bounce, hop, and single leg running. So this is a load test that you can do. And this is just what we've discussed now, just to show you the type of evidence that we have. As you can see, there's still a paucity of literature, very much based on expert opinion, unfortunately still. And this is a very nice flow diagram. You might not be able to see this clearly, but it's something useful that you can use in your clinical practice. So if the patient return, is it before 3 months? And it's no, they're not supposed to return to running. If it's after 3 months, yes. And then you will scan through all of these things that we've just gone through in the presentation, and it will show you where to go. So if they don't pass the screening and have any of these pelvic floor dysfunction or pain present, they will be referred to the necessary practitioner before they can commence the return to running program. This is just an example of an exercise progression for early postnatal period in the first 3 months. It basically is the same that we will usually do. We will start with core training, then we will go over to more strengthening training and more global stability, and only then we will go to the functional training and the more aerobic type of training such as spinning, swimming later on. And this is for return to running if the patient only starts return to exercise after 3 months postnatally. And then the last slides are just some interesting evidence that we also have. There's the correlation between weekly training load and continence we have, but there's not a correlation between muscle function and running kinematics. So it doesn't necessarily have to do with the way you run. It's more about the load that you are opposed to. And this is also just interesting to see gymnastics usually has the highest prevalence of powerful dysfunction because it involves the most activities which increase intra-abdominal pressure. If you look here, you will see running is by far not the activity which creates the highest intra-abdominal pressure and ground reaction forces. Jumping is more, and landing activities is more the problem. And this is just according to sport modality. Again, we can see in gymnastics, we have the highest prevalence there, again, due to those impact and the forces that are created. So just in conclusion, we need to realize what the importance of antenatal exercise is, because you saw if it's a patient that has participated antenatally, she can actually go back to a season if she has some proper training and exercise during this period. The first 3 months postnatal is the recovery time, where you need to address any physiological changes or problems the patient might have. And then when they start returning, you start with your core training, your strength, low load cardiovascular for the first 3 months postnatal, and then they can go over into return to running program. After the 3 months, if there is no contraindications or specific precautions that you need to take into account. And I think it's more about the load of the exercise and that we prescribe them than really the type of sport, unless it involves jumping, as you saw, of course. So we need to focus if a patient has problem. Is the load that we prescribe the right load? And that's where the assessment again is very important in this patient. So I hope you've learned something. There's a lot of information here, what I will be happy to share with you so that you can go back and read through it in more detail, specifically the programs if you would like. So thank you very much for the opportunity, WiSH and Belinda specifically.
Thank you very much for that talk, Dr. Brandt. Please stop your screen sharing. Thanks very much. I think the take-home message for me after tonight's webinar is basically, individualize your prescription and your training for each patient. Depends on what they've been through in terms of their pregnancy, their delivery, and then prescribe exercises individually. So we've got, hopefully I'm going to try and just get through 1 or 2 questions, if we may. The first question is probably to Dr. Barsky, where it says exercise medicine guidelines on their website says that women should do at least 150 minutes of moderate intensity aerobic activity during a week during pregnancy and the postpartum period. Preferably aerobic activity should be spread throughout the week. And she says, please leave comments, especially in the postpartum phase.
Okay, so I don't disagree with that, but again, we want to, I think what we need to just stress is what you just said is in terms of individualizing for each person. So, and what is reasonable and what is manageable and what is practical. Remember we spoke about not putting that pressure on someone. There's so much to cope with in motherhood. Becoming a mother is listed as one of the 5 main stresses of life, including death of a spouse, moving house, losing a job, loss of a parent. It's up there. So there's lots there. And I think it's very much based on what the person can manage and at what stage in the postpartum period you are at, that we would then, that you would enforce it. But I would always encourage someone to get active if they have the time, if they have the need, and if clinically there are no contraindications, then why not? And I think what between Dr. Brandt and myself, what we're also just trying to stress is just be careful of the load and be careful what you do. So, so rather than, I think it's just to be careful about it. I hope that answers the question.
Thank you. Another question says, the American Society of Obstetricians and Gynecologists in May 2018 defined postnatal care to the 12th week instead of the 6th, defining this phase as the 4th trimester because of the vast changes a mom undergoes in this phase. Would it be prudent for a woman who has returned to moderate to high intensity training to see a sports physician for a check in the 12th week? She says she's seen many women really struggle with deficiencies such as iron or burnout or call it depletion, and need to hear from a doctor how their bodies are coping, or need advice on supplements. So is it good to see a physician?
Yeah, so I'm going to go to the first question of, is it prudent? And as we've just learned, and I think Dr. Brandt again highlighted very beautifully and very eloquently that the first 3 months are a recovery stage, and I would not advise a postnatal woman to take on any moderate to high intensity training in the first 3 months of postpartum. So that's my first answer there. Just from, and it's based on, it's completely my experience, and we know there's not enough evidence out there, and not even enough expert opinion out there to encourage that. So I'm not surprised that someone who's taken on moderate to high intensity training in that period is suffering from an energy deficiency. Would I supplement? Yes, I would. But I think that person, I think that person not only needs the physician's role here is to see what is driving that. I would be very much worried about postpartum depression in someone like that, because that is to try, that's my comment on that question.
Always remember, as a runner, I think, the reason we run in the first place is for our own peace of mind. And I think in the case of not being able to run after pregnancy, I think that mental aspect is very important, which could obviously be what drives the patient obviously to push themselves too hard, because they just want to get back to that, their happy place. We have that happy place.
A happy place, and it's a lot of things, because in pregnancy you slow down tremendously. So I mean, yes, you can maintain your pace and whatever, but if you do slow down as much as you try and push yourself, and you can still exercise to a high intensity, but you will find that there definitely are changes to your pace. And I'm sure we'll have comment to say, when I was pregnant and I ran and my pace was fine, will obviously be the exceptions to the rule. Yes. But the blanket statement is you will slow down, and then you have your baby and it's like, yes, I can get back there, and then you're trying to kind of force it a little bit. So it's just, there's lots to take into account. And I think as the healthcare workers supporting athletes like this, we've got to do exactly that, support and guide and give a little bit of nurture as well.
With time constraints, I'm going to ask one last question. And what objective measures can we give women to follow to remain exercising within a healthy capacity? So, nowadays everyone has smartwatches. So, monitoring resting heart rate, what variability is a sign that they should back off? And then sleep quality. People nowadays monitor their sleep quality, they monitor resting heart rates. What is an indication that they need to back off, or they're not getting enough sleep and they maybe need to take a day off?
Oh, that is, I don't know if, I have a lot of answers to that, but I don't know if Dr. Brandt wants to comment there also. Okay. I think specifically in the postpartum period. Oh, sorry. Go for it.
No. I'll add on to your answer. I think maybe first have a look at the physiological aspects, the heart rate, those type of things, and then I can add on to some musculoskeletal things.
So I think in terms of heart rate, remember we have the heart rate variability that happens during pregnancy. Heart rate goes up in the first trimester, it then stabilizes, and then it goes up that little bit more in the third trimester, and then it takes a little bit of time for everything to settle. So in the postpartum period, remember we spoke about those the cardiovascular changes and how everything kind of reverts back to normal, but is never the same as where you were before you had a baby. And yes, you can get fit and your resting heart will get low and all of that. But I think in terms of when is enough, I think it's based on many things. Is if you're not coping, if you're not coping in the day, if you have excessive fatigue, your pelvic floor, huge indicator as well. So I think it's not, I think we rely too much on our smartwatches and forget about that there's actually a person connected to the watch. And it's not just about the readings on the watch.
Thank you. Dr. Brandt, anything to add?
Yeah, I think also just what I've mentioned earlier, if they experience any of those symptoms of pelvic floor dysfunction or, musculoskeletal type of symptoms, if they have any pain, if they have a feeling of heaviness, discomfort, that's a sign that there's something maybe not right. And then, we have screening tools that we can use to screen patients for that, to see if there is anything, especially if it's, early on in the recovery or in the return to sport phase still, where there's still maybe a chance of those things occurring. And also, as we said, these things can take up to 1 year to really resolve properly. So I think in that first year postnatal, if something doesn't feel right, just go and check, go for an assessment that someone can just maybe help you identify any muscle imbalances specifically, or maybe just screen for, do you have maybe a slight pelvic floor dysfunction? Remember, you get different stages and levels of pelvic floor dysfunction. You can have you don't need to have a stage 4 pelvic floor prolapse. It can be a stage 1 or 2, which you might not even be aware of unless it picks up on a sonar. So, and it might also not be symptomatic. So there's lots of things that can still occur in that first year. So I think, when you feel any symptoms, I think the best thing is just to get an assessment and to resolve that early on, because the longer you wait, the more difficult and obviously the more severe the problems can become.
Perfect, thank you. With that, unfortunately, we are out of time. I see there are still a few more questions, but we won't have time to answer that this evening. So just a couple of thank yous. So number one, thank you again to our speakers for this evening. Talks were excellent, very informative, very educational. Thank you very, very much for your time. Thank you to the attendees who were on the webinar. Thank you to the sponsors, so Senior Letha. And then I'd also like to just thank Dr. Robin Sagers in the background for setting up the technical aspects of the webinar for us this evening. So guys, when you leave the webinar, you'll complete a survey so that you can get your CPD points. And then all the articles that were referred to will be sent out with the email tomorrow. Then next week's webinar is on the posterolateral corner of the knee by Dr. Glenn Vardy. So please join us for that next week. Again, thank you to Senior Letha. Thanks for everybody who joined us, and to all our speakers. Have a good evening, everyone.